right, many thanks for staying with us. And you are still watching Good Morning Nigeria on the network service of the NTA. Just before we bring in our guests for our conversation on health financing in Nigeria, let's take these background reports put together by Ibrahim Hamidu.
Healthcare is a human right. Yet, for millions of Nigerians, paying for treatment remains a daily struggle. From rural clinics to city hospitals, families still dig deep into their pockets, with out-of-pocket payments making up over 70% of health expenses. It is a burden that pushes many into poverty and leaves the most vulnerable without care. That is why the conversation around health financing is no longer a choice. It is an urgency. Just yesterday, at the National Health Financing Dialogue in Abuja, policymakers, development partners, and stakeholders asked, how do we reimagine the future of healthcare funding in Nigeria? The challenge is clear. Nigeria spends less than 5% of her GDP on health, far below the 15% Abuja declaration target. Primary health centers lack basic equipment. Teaching hospitals face strain, and doctors and nurses continue to leave in search of better conditions abroad. Yet, there are pathways forward. The Basic Health Care Provision Fund is being strengthened to guarantee minimum care for all. The National Health Insurance Authority is rolling out coverage to millions, with plans to bring more informal workers into the net. Innovative ideas are also emerging: state health insurance schemes, public-private partnerships, and digital platforms to track spending and improve transparency. But the big question remains: how do we raise and pool more funds without overburdening citizens? And how do we ensure every naira translates to real service delivery, medicines on shelves, ambulances on call, and health workers paid and motivated? Across the world, countries have shown it is possible. Ghana and Rwanda have achieved broad health insurance coverage. European systems are built on sustained public funding. For Nigeria, the road ahead demands political will, accountability, and citizen trust. Today on Good Morning Nigeria, health financing experts, policy leaders, and sector professionals will discuss how to turn ambition into action and how to build a system where no Nigerian is denied care simply because they cannot afford to pay.
Many thanks, Ibrahim Dan Hamido, for that beautiful package, of course, which sets the tone for our conversation this morning on health financing in Nigeria. And we have with us the pleasure to have the Honorable, if you like, I should say Coordinating Minister of Health and Social Welfare, Professor Mohammed Ali Pate. Many thanks for joining us, sir.
Thank you for having me.
All right, and also here for the conversation is Professor John Eli Ojo Atuguba. He is Canada Research Chair in Health Economics at the University of Manitoba, Canada, and Executive Director, African Health Economics and Policy Association, Accra. Many thanks for joining us, sir.
It's a pleasure.
Welcome.
Thank you.
All right. Also joining us here in the studio, we have Dr. Gafar Alawode, who is an expert in health financing. A pleasure to welcome you to Good Morning Nigeria.
Thanks for having me. Thank you.
Now, let's begin this conversation with the Honorable Minister of Health and Social Welfare. How does this health financing package make life easier for Nigerians? How does it impact coverage, for instance?
So the goal of any health system is to improve the outcomes, the health status of the population, but also in a way that doesn't expose them to catastrophic or impoverishing health expenditures, so as to have the protection from those expenditures that can tip them into poverty, as well as to ensure that everybody is carried along. Now, these reforms that are being undertaken over the last 2 years in this government are aimed towards achieving that, towards saving lives, reducing physical and financial pain, producing health, and doing it for all Nigerians. And if you look at it broadly, for a very long time, the national consensus has really not prioritized health the way it should have been. And that was reflected in the way that we deployed resources, the tax revenues, to really support the investment in infrastructure, in human resources, in equipment and in commodities. Well, over the last 2 years, what we have seen is that President Bola Ahmed Tinubu has deployed significant political will in the choices he has made, both at the macro fiscal level in terms of the overall macroeconomy, the reforms that have been undertaken, the tax reform that is undertaken, and also the prioritization of health within the context of public policy. And these reforms that have been undertaken over the last 2 years initially focused on the supply side, the primary healthcare, the facilities, the human resources, the supply systems, but in tandem with that, the demand side, the access side, the affordability to ensure that pregnant women, for instance, who require emergency obstetric services, the cost of accessing cesarean section doesn't cost them their lives. And so how do we reimburse that? That requires resources. Anywhere you see expansion of health insurance, affordability, somebody else is paying, and usually it's tax financed. And you cannot connect some of what's happening at the macro level, the fiscal policy reform, the tax bill, the tax law, for instance, with the revenues that we're seeing increasing dramatically. That is what will allow us to then make healthcare more affordable to Nigerians. So it's all sort of interconnected. And over time, what we hope is that basic healthcare be available to all Nigerians, regardless of where they live or their income, their gender or their age. So that basic services is guaranteed. Immunization, primary healthcare for mothers, treatment of common illnesses, non-communicable diseases. And then at the higher level, the provision of health. Of course, there's a large private sector that provides, but how does government purchase that for those who need it and for those who can also pay? And others may subscribe to private insurance or to use private insurance as a complement. So what has happened in the last few days is that the president mandated all MDAs to insure their workers, but also all compliance bodies to ensure that those who interact with the federal government also insure their employees. It's signaling this direction to expand the risk pool, so that the wider the risk pool, the wider the insurance pool or the contributory scheme, the easier it will be for Nigerians to access healthcare when they need it. And they will then access the healthcare earlier rather than later. If you are not insured, something that might be stemmed on day one, you may delay 4 or 5 days to see whether it will go away. And by the time you get to the facility, it may be more serious and cost a lot more. But if you know you have prepared scheme, the first day you have fever, you will go to a facility, you will be tested and treated early. So that's the way that we think this is unfolding. And the consensus that has emerged now in our country is now gone beyond the president. You saw the Minister of Finance, Minister of Planning, you saw our external partners, you saw civil society, our academia, our state governors, the Governors Forum, local governments. So there's a national consensus evolving now around the centrality of the need to invest in health, in human capital, in social protection. And that if we do that, the vision of a prosperous Nigeria built around the people of Nigeria, around the human capital pool that God has given us, and the social capital that we will harness from that will only propel us forward. And that is the consensus that I believe was lacking for a very long time until we saw the leadership of this president.
All right, brilliant, Professor Pate. I mean, you've talked about the insurance pool and how this would help the health sector. But a lot of people say there are so many challenges in the health sector, away from infrastructure, you have personnel, you have, just a whole lot. And some have termed the health sector as being critically ill at the moment. So do you think this insurance pool will be enough, considering the fact that the budgetary allocation, for example, this year, just about 5.18%, that's 2.48 trillion naira. Do you think that this insurance pool would be able to do the magic if government does not improve its allocation to health?
So I think you have to be very careful about narratives. And the narrative that health has been underperforming over time, I think it's true that for a very long time, Nigeria had not invested enough in the health of its own citizens, in the infrastructure and the equipment. That is true. The consensus among elites has been everyone takes care of him or herself, private sector or fly abroad. But that is changing. And in the last 2 years, we've seen more than doubling of the revenues of the budget that is allocated to health at the federal level. And with the increasing revenues in the states, we're also seeing some states exceeding the 15% of their budget to health. And we're seeing better quality of the spend. We're seeing improvements in the infrastructure. Some of those narratives that you have are now becoming dated, because the reality is that we have some of the latest equipment for cancer treatment in Nigeria as you will find anywhere in the world. The primary healthcare, thousands are now being revitalized. Basic healthcare provision has been enhanced, and health insurance is being expanded at a pace that we have never seen it before. So 5 years ago, I would say that yes, because the national consensus and the political will wasn't there. But right now, I will say, and you have seen the finance minister, governors, everyone, there is a national consensus. It's not, health is one area where it's not just one entity or one level of government that will fix it. It's us, Nigerians collectively. It's the political leaders, it's the legislator, it's the president, it's the governors, it's the civil society, it's the media, is our external partners, because health is something that affects everyone. If there's one thing that should unify Nigerians, in fact, it's health, because there's no one who is immune to the risk of ill health, or their families, or their neighbors. And so that consensus ought to have been formed. It wasn't. And the prevalent narrative among elites is to look down and say, oh, things are not getting better, things are bad all the time. But it is possible, it is us, Nigerians, that would have to forge that consensus that we can do it, and we can fix it, and we begin to fix it. Have we fixed all of it? No. Do we have enough resources? No. But we have started on a path that if we sustain it over time, and each one of us does their own part, then we will get the health system that we desire for ourselves, for our families, for our neighbors, for our citizens, and importantly also for fueling the growth of our country in an inclusive manner.
All right, thank you, Professor Pate. Now, Yuri had asked the question about finance, which is what all of this is all about. The new taxes on tobacco, the new taxes on sugar, is it also part of it? And is it enough? Because indeed, finance is everything. Even if you talk about the shortage of manpower, it is because they feel they are not getting a fair deal that they are leaving. And so if we are able to keep them, it will also require more financing for them. So does this suffice? Sugar, tobacco?
So you look at total spending, total health expenditure in Nigeria. A large portion of it is private, is households paying out of pocket, and that's not an efficient way of mobilizing resources for health. The public sector puts about 25% or thereabouts, and external finance is about 5%. But because government revenue has been very low for a very long time, among the lowest in the world as a portion of the GDP of the country, the size of our economy, we've not been spending nearly enough that we should have spent given the size of our economy. Now we're seeing improvement. Tax to GDP has increased in from 2023-24 from 7.5 to 11.5%. Still relatively low, but for the first time you're seeing a jump. And you're seeing larger portion of federal budget allocated to health. And that is signaling the direction of travel. And that has to be sustained. And what we did this week was to encourage states also to complement what the federal government is going to do. There are other instruments of raising resources for health. What you mentioned, the so-called health taxes or sin taxes, taxes on tobacco, excise taxes on tobacco, on alcohol, on sugar-sweetened beverages. This is a very important point because the fastest growing segment of disease burden in Nigeria is non-communicable diseases, hypertension, diabetes, peripheral vascular diseases, strokes, cancers. Those diseases are in part because of some lifestyle choices. Tobacco is clearly bad for people's health. Excessive alcohol use is also not good for health. Sugar-sweetened beverages, there are indications that they contribute to some of the diseases that we're seeing. And globally, there is experience that if you put excise taxes to a certain level, you can discourage consumption of those in a way that will protect public health. So you can achieve public health objectives as well as at the same time achieve fiscal policy objectives because you get more revenue which can be used to invest in health and also invest in other areas that have influence on health, whether it's water and sanitation, whether it's food and nutrition, because you can also have that. So that framework is currently being developed. We're advocating a careful consideration for this option, but there are also other fiscal policy options that are on the table. For instance, the taxes and tariffs in the tax law that was signed, which will come in 2026, there will be zeroing of some taxes and tariffs for investors, for instance, in manufacturing locally to lower the cost of production, which is building on the executive order that the president signed in 2024. There are other measures like the deductible donations, so that if you make a contribution in the health area, it's tax deductible. That's common in many other. So there are also private sector ways to leverage public capital, private sector expertise, to bring private capital innovation, to deploy in expanding the capacity of the health system, whether it's on the supply side or even on the demand side. So all of those are important elements, but they will only be possible if there is a political will at different levels, federal, state, local government. Now we have the stars aligning in that direction. And also the willingness from the citizens, because it's taxpayer money. If Nigerians don't say health is a priority, they don't complain about it. The political leaders don't have to do anything about it. But as Nigerians, we have been advocating that, look, we need a better health system. And now the president who was elected by Nigerians is beginning to deliver on that. And we need to support him to sustain that direction alongside many other major reforms that he is putting in place, which will elevate this country, which will change the direction and the narrative of this country and will put it in the eyes of the world. And one last thing, this has been noticed, not only here in Nigeria, but in Africa and globally. This dialogue we had, there's a country, Senegal, the Ministry of Health, Ministry of Finance, Ministry of Budget, they were there. They came all the way to study what Nigeria is doing. There are other African countries that are now looking to say, how is Nigeria doing all of this because of the president's leadership? Globally, there are 1,300 people who observed this dialogue. So there is something positive happening, but we have to believe in ourselves and respect ourselves to accept that this country can change for the better.
Many thanks, Professor Patti. I'll get back to you, but let me quickly introduce another guest joining us via Zoom all the way from Lagos. We have Abayomi Olarinmoye. He is a senior partner at Veraki Business Solutions for Africa. Many thanks for joining us, ma'am. It's a pleasure to have you.
Thank you. Good morning.
So we'll get back to you shortly. I'd like to remain with the Coordinating Minister of Health and Social Welfare. Earlier when you spoke, you talked about getting organizations get their staff insured just so they can access healthcare as fast as possible and as early as possible. But I'm thinking about those in the rural areas who do not work for any kind of organization, who do not work for government, they're not in NHIA and all of that. And for them, the only way most times to access health is through the primary healthcare facilities. Speak to us. With all of this that you're doing in the health sector, how is it going to change the narrative as far as primary healthcare centers are concerned?
So to put it simply, there's sort of the formal sector employee, public sector, the private sector, large private sector, who are covered with this mandatory the mandate. Then there are the informal. We've got a very large informal sector, some of which you've sort of alluded to. How do we make it easier for them to enroll? How do households contribute? And NHI has an enrollment portal that individuals can actually enroll in that direction. The culture and mindset of prepayment for health, I think, has to be, let's say, expanded in our population for even those who are in the formal, to see it's in their interest to insure themselves and their families, to contribute to that. Then there's the vulnerable populations, those who are living on less than $2 a day, for instance. It's difficult for them to actually pay the premium. Somebody has to do it. Whether it's the UK, or in Scandinavia, or in Kenya, or even Ghana that you refer to, is taxes that pay the premiums. Somebody has to pay for insurance. You can't insure somebody in their absence, but somebody has to pay the premium. And in all areas where you see expanded health insurance, there is tax revenue that is channeled towards that. In Nigeria, we have the Vulnerable Groups Fund. The Basic Healthcare Provision Fund is 1% of consolidated revenue of the federal government portion of the federation account. 1% of it gets allocated to Basic Healthcare Provision Fund, and half of it goes to the Vulnerable Groups Fund, which is used to provide capitation payments for primary healthcare for population who are vulnerable, women, children. In addition, you have heard the effort to provide reimbursement for emergency obstetric services. Women, pregnant women, and their babies are vulnerable. So because of the high mortality we see, maternal mortality, that is also another way to provide succor for them. Women who have obstetric fistula, disabled as a category. My goodness, even Almajiris and out-of-school children. We now have an out-of-school and Almajiri health scheme that we are working with the National Commission for Out-of-School Children and Almajiris to ensure that we start to put in mechanisms to provide for their health needs, because the society that we should aim for is one that is inclusive, that does not, let's say, we are our brothers and sisters keepers. That is the direction of travel, the principle that we should abide. So those are also being catered for. The limit will be the revenues. Now, if many Nigerians don't pay taxes, or they evade paying taxes, or we don't collect the taxes that are due, or there are leakages in collecting the taxes, the tax authorities will not have enough revenue to pay for security, pay for education, and pay for health. So if we get the culture of everyone paying their taxes, there will be sufficient revenue to provide for what you need through the formal sector, but also take care of others who may not have those wherewithal to be able to pay for themselves, because we are all in one. And it is in our enlightened self-interest to have that. Because if you have a society where everybody in Abuja is insured, and they have the best quality services, but somebody in Talata Mafra in Zamfara is uninsured, you know what? They can have an infectious disease that may not be treated very early, and it spreads, and somebody brings it to Abuja, and you can be affected. But if you insure them as well, and ensure they have access to services, you are in a way protecting yourself, whether it's tuberculosis, whether it's some other infectious disease. So it is in our collective enlightened self-interest to ensure that we don't leave other Nigerians behind because they are living in rural areas, or because they are poor, or they are on the streets. No, we have to think of it in a universal context. To achieve this universal health coverage is in our enlightened self-interest to build the human capital, to protect our society in terms of its resilience, to also build social capital, because the divisions in our country, the pain, the hurting in our country, which has been for a very long time, it can be healed using the instrumentality of health. Because if everyone feels the sense of belonging, there is a sense of unification, let's say, that you can say that you are helping someone else. That's a behavior that needs we need to sort of build, basically, so that we are also, it's not just about yourself here in Abuja or in Lagos or in big capitals or the elites, but that there are those other Nigerians who are disadvantaged. How do we also ensure we take care of them? If you do that, they are less likely to take up arms against you or throw stones at you or even have infectious disease that they can spread to you. So that's the general idea. And that's the direction of this administration. And I really think the president is very wise
Beyond
in taking that
ensuring
path.
those in rural areas and those in underserved areas, how do they access quality health care? I'm thinking that, there's so many communities without even a primary healthcare center. So, well, ensuring is one aspect. Access.
Yes.
Is, so how do you want to bridge that gap?
At the very beginning, if you heard correctly, I said that we spent 2 years putting in place mechanisms on the governance, but also on the supply side. So that's the physical infrastructure, the revitalization of the primary health care. Thousands have been done and more are on the way. The functionality of what we have, more than 8,000 have been receiving quarterly disbursements from the federal government. The retraining of 67,000 and more now of frontline health workers, the equipping of those facilities, and that more are going to be done. Ensuring the commodities are available. I think there is a lot of work to be done in that direction. That's on the supply side. So to provide quality services, you need the supply, you need the standards, but on the affordability, if you provide the supply and people are not able to afford it, that's also a challenge. So the Vulnerable Groups Fund, for instance, has been expanded, and we're continuing to double down on that so that it provides capitation payments for a lot of populations to actually afford those services. Let me tell you, there are women who die because they cannot afford 200,000 naira to have cesarean section when they require them. They are pregnant women. And I can tell you stories that came to our attention. Federal government jumped into it, raised the resources, and put a mechanism through the Health Insurance Authority to empanel some facilities. And more than 5,000 women so far have had cesarean sections reimbursed by the federal government. So they have accessed quality care that they need, and without exposing themselves or their families to catastrophic health expenditure or impoverishing health expenditure. Same thing with the fistula. There are women, 12,000 a year in Nigeria, that have obstetric fistula from complications of delivery. They are excluded by their society, sent away by their husbands because they're smelling of urine. The elites will say, oh, it's okay, they don't even see them. But they exist. So by bringing them into the fold and working with HMOs, the NHIA has now pulled together a mechanism to get them fixed at no cost to them, to empower them and integrate them back into society, and some of them are getting back their lives. So they're accessing quality care. So this is not abstract. This is real, it's tangible, and you can count it. That is what is happening. But because some of us are a bit far removed from where these difficulties exist, are a bit insulated, we may not appreciate the transformation that is beginning to happen. And those that are out there may not have the voices to be able to tell. But if you go out, go to NHIA, they can show you the numbers and show you where you can find those people who are benefiting and accessing, who ordinarily were excluded. Because the Nigerian elite, I think we have been very good at capturing the benefits from public resources, more so than the poorest of the poor among ourselves. We are changing that. That is what this administration is trying to do.
Thank you very much, Honorable Minister. Let's give you a well-deserved breather. Let me get to Professor Atagba. From a health economist's perspective, would you say that Nigeria is finally trying to spend its way to universal health coverage, or are we still trapped in some form of unsustainable health financing model?
Thank you very much. That's a very good question. It's not as simple as you think to just give a yes or no answer. But what I would say, just to also piggyback on what the Honorable Minister talked about in terms of countries moving towards universal health coverage, no country has gotten there. It's a journey. But given that Nigeria has made significant commitments in terms of pushing the country on a trajectory that takes it closer and closer to a place where everyone could have access to quality healthcare? I would say yes, but there is still a long way to go. A long way to go in the sense that many countries that have been able to successfully achieve a significant portion of coverage have done that through a combination of contributory and non-contributory schemes. Nigeria has both, which is good news. The contributory aspect is contributing to the national health insurance as well as through the state insurance as well. And the non-contributory part, which is very good in Nigeria, it speaks a lot to the Basic Healthcare Provision Fund. Now, the non-contributory part is the one that we need to pay attention to. The reason why we need to pay attention to that, and which the current administration has really given thought to it, is that it covers predominantly those who are unable to afford health care. And Nigeria sits with a population that is large in terms of informal sector. The informal sector accounts for a large share of those who are employed. And there is, of course, a substantial number of unemployed people, not to also add those who are impoverished, who are already poor. You cannot conceive the ability to pay for healthcare. So that non-contributory part is a very essential part. So combination of both the contributory and the non-contributory will put Nigeria on that path. The challenge, however, is how do we drive down out-of-pocket payments? Out-of-pocket payments are very, very toxic because they hit you at a point when you least expect them. Illnesses hit. You don't know when they're going to come. They come like shocks. And when they hit you, I mean, you have to begin to run helter-skelter looking for funds. So if we can drive down out-of-pocket costs significantly, I think we are there. No country achieves universal health coverage with the kind of large out-of-pocket payment we have in Nigeria. If you look at all the countries I've studied over the years, you see Nigeria is really top in terms of out-of-pocket spending as a share of current health expenditure, which is not good news. But the current trajectory of travel will, if done well, which I think it will, given the kind of hands we have, and also commitments from both state and, well, from all tiers of government, state, local government, and federal, I think the country can achieve that.
All right, many thanks, Professor Ataguba. Let's get to Dr. Alawode now. Professor Ataguba, you are a Nigerian outside the country. Dr. Alawode is here with us. He knows our issues. He sees it every day. Speak to us about this initiative by the Ministry of Health and what this present administration is doing. Do you think it would in any way change the narrative in the health sector? Would it really affect the poorest of the poor? I mean, that poor farmer in that village, would it in any way improve our health sector?
Okay, thank you very much. I think let me start by actually building on the bigger picture that the foundation led by the Honorable Minister. Brigade said something. He said, if you want to fix a complex problem, ask two questions. The first question is that who has done it very well in the past and what should we learn from them? So what have we learned globally in terms of achieving what you've asked about and what is actually obtainable in our context in Nigeria? I think, so there's a common saying in the health financing space that the starting point of universal health coverage is not technical, it's the political consensus. And as laid out by the Honorable Minister, I think the first thing that is happening in Nigeria, which we should leverage as much as possible, is what we are seeing at the political consensus at the highest level. In December 2023, Mr. President and the Honorable Minister, they called all the governors and the stakeholders, and there was a compact signed, spearheaded by the Honorable Minister. Mr. President was there himself in terms of saying this is the direction of travel. All stakeholders, we have agreed, we have signed a compact, and which is driving things. The second thing which is happening, every health system operates within a fiscal environment in terms of money, revenue of government, and all those stuff like that. One of the reasons why the spending on health has been so low is that even the ability of revenue collection ability of the government was very low. We have seen things are improving. And not only that, we have seen the managers of the economy, the Honorable Minister of Finance, the head of the Budget Office, the tax reform, all of them are speaking to the need for improved investment in health because, of course, everybody's human being, we need health. But they've seen the contribution of health to the larger economy as well. Recent report from Lancet says that health is contributing around 7% of GDP. That's not a sector to ignore. So we're having that. Then, in terms of the path towards universal coverage, two things are very, very important. So there's need for mandatory participation in any financial protection scheme, and there's need for subsidization of poor and vulnerable, which were lacking in Nigeria health financing or insurance ecosystem before now. We have seen those now. Recently, all of us, we had Mr. President, of course, with the great work done by the Honorable Minister, have actually approved mandatory participation because, and it's very, very simple, when you are saying health insurance is about subsidization, it's social solidarity, where people that are of low risk in terms of if I'm rich, for instance, the risk that I will not be able to access health care is very actually low. The risk that I'm going to be impoverished as a result of health spending is got very low. But for a poor person, it's very, very high. So the fundamental principle of cross-subsidization is not going to work unless you have a mandatory participation system, which the president has given rise to. In terms of the poorest of the poor, because even when you say the premium for health insurance is 500 naira, there are Nigerians that are not able to pay. So how do we get those ones? Honorable Minister has spoken about it, but one other thing that would add to that is that I think the NHIA is now very, very intentional in going about with the pool of funds that we have. How are we going to reach the people that need this money most? And they have the digital technology which will help in terms of identifying, okay, if I want to enroll you, I'll ask you a few questions. By asking you questions, I know where you belong in the social structure. And then I'll be able to say, with this little amount of money for poor and vulnerable population, this is where we are going to send it. I think pulling all these things together, including investment in primary health care and others, I think we're on the right trajectory. And don't forget that it's not only about the volume of the money, how we effectively pull the money together. Another thing which is very, very important, which the Honorable Minister spearheaded, is the sector-wide approach. Before now, we have partner, private sector, government spending money in an uncoordinated manner. You understand? And when system is not coordinated, 1 + 1 or 2 + 2 can be 3. But where there is a well-coordinated whatever, 2 + 2 could be 5 or 6. And that is why we are saying in terms of optimizing the resources that we have. So what is very, very important, and I was very excited with what you saw during this financing policy dialogue. A number of things happened. We have seen that political consensus, but in practical terms, we have the legislature saying that the basic care provision fund, we are going to increase the share from 1% to 2%. That's a lot of resources. And then of the ministry is very intentional in terms of this additional money, where are we going to see it? We are taking advantage of tax reform. And I was very happy when Tai Olejole made a presentation. And he said, okay, we are looking at these health taxes that we are looking at. What are the practical way of because when we call it health taxes, and it's no proportion of it is coming to health, we are saying that as well. I think that's a very, very important thing. So a number of things are actually coming together. And what is important now is that all of us to work with the Honorable Minister, to work with experts, including the media, to hold the system accountable as much as possible. So finally, I think it's a journey. And when you are on the journey, there are 3 questions. Have you started? Are you on the right path? And are you having the right pace? I think we have started. We're on the right direction. In terms of pace, we could move faster. But at the same time, all of us need to come together to ensure we get there.
All right, Dr. Alaudi, thank you very much. I'm interested in knowing from you, maybe much later, why it appears that in Nigeria, very promising health initiatives don't seem to scale. But we'll get back to you. Let me get to Abayomi Olanimoye. Now, the private sector often says that the government cannot fund health alone. But where do you see in all of this the opportunities for the private businesses to step in without turning health into a luxury?
Thank you very much. I see 3 opportunities for the private sector to partner with government. The very first opportunity is for private sector institutions, organizations to fund healthcare provision in some way, building hospitals, funding healthcare by ensuring that the systems are in place. If private sector organizations adopt a few primary healthcare centers, ensuring that they are well equipped, ensuring that they are well stocked in terms of having the right drugs, ensuring that the personnel are well trained. This helps. This helps because I think there's a way that they can collect back a rebate, get tax incentives for every naira, for every dollar they invest in improving healthcare outcomes in Nigeria. So that is one way to do it. Private sector funding healthcare and getting tax rebates, tax incentives for this. Another is directly partnering with government, and we already see them doing this. Cancer care centers are being built. If we identify the top 6 or top 10 diseases, including non-communicable diseases like the cancers, and we get private sector organizations to help put in place the right infrastructure to encourage the treatment of these non-communicable diseases, it will go a long way to ensuring that healthcare outcomes are met. So one way is funding it directly and getting tax rebates. Another is partnering with government to build and to run efficient systems. The third way is data. Private sector organizations can help put in place systems that will be able to track healthcare outcomes as well as healthcare spending. Given the advances that have been made in technology, it is possible for private sector companies, organizations, to help invest in the necessary technologies to ensure that budgetary spend on health by government as well as private sector spend on health is tracked, and that outcomes are also tracked to ensure that the results are being delivered. Thank you very much.
Many thanks, Bayomi, for your input. Just to let our viewers know that they can send in their questions, comments, suggestions, whatever it is, to the number on the screen. I would definitely read them, and I'm sure the minister and our other guests would respond to your questions. All right, I'd like to get back to the minister now, Professor Pate. This is a beautiful initiative. Listening to our guests, it looks like this is the way forward for us. But, you know, when Dr. Alawade was speaking, he talked about 2 plus 2 becoming 5 or 6 and not becoming 1 or 0. You know, I mean, transparency, monitoring, and all of that is important in all of this. Speak to us about how the ministry intends to measure the effectiveness of these health financing reforms and what indicators will be used to track the progress.
So the first pillar of the blueprint that was unveiled by His Excellency the President in 2023 was to look at the governance of the health sector. Not the technical pieces, but the governance first. Because that had been the challenge for a very long time. We're a fiscally decentralized system with federal government, states. We've got local governments. We've got multiple development partners that are doing their thing in various states, private sector, regulatory bodies that are also there. The data, without data, you can't even talk about accountability. You just have stories. Or the citizen orientation, I think, was a bit lacking. And so we took that very seriously and had a Citizens' Voices survey Yeah, we've now done 2, and the third one is being done. We engage with civil society organizations to sort of listen, what do Nigerians expect? What is their experience? How do they want things to evolve? Looked at the regulatory bodies to ensure that they do what they needed to do. But the compact that Gafar mentioned essentially brought everyone together so that there were asks and offers. For the first time, we have a compact between federal government and states and local governments and development partners. Say, here's the path of travel. Here is our North Star. Here is how we're going to tell you that we're making progress. Here is how, on a quarterly basis, we'll have a performance dialogue. And we have been doing this performance dialogues with the various states on a quarterly basis, on the basis of certain indicators. And here is how we're going to do a joint annual review. We had the first ever joint annual review of this effort in 2024, and the first State of Health report of Nigeria developed out of that with a scorecard for each state, showing, based on the data available at DHS, who is improving and who is not improving, and what do we learn from that in an open way. This was done publicly in November 2024, and now we're preparing for the second joint annual review. So there are mechanisms in place to organize the sector better, so that there is better coherence and structural mechanisms to allow us to take stock, and on the data to look at, okay, what is the source of truth? In the past, we have multiple sources of truth. When you ask, what is maternal mortality rate in Nigeria? What is the immunization rate in Nigeria? You'll hear numbers that are very, everybody has his or her own numbers. But now we're streamlining to say, okay, let's take one instrument, a survey instrument. Let's also use the DHIS tool and agree that that's the basis for our source of truth. So we're speaking to the same numbers, imperfect as they may be, because if it is a routine data, there may be incompleteness, there may be capacity issues, but at least let's start to use that data and then improve the quality of the data, audit it. Surveys, we're going to do a mini demographic and household survey that will go deeper in some states in 2026. We had one in 2023, so that we begin to have data to tell us, are we making progress, are we not making progress? And it's common in Nigeria, we say that we have faith-based policies and programming because there's no data. People just believe, okay, I believe this is so and so. I believe that things are not improving. I believe things are just bad because that's what I had believed 10 years ago. But to move towards more evidence-based policies and programming so that we can say with the numbers, if you're listening carefully in the health sector right now, people are talking about numbers. They're talking about numbers of primary healthcare centers, talking about utilization, talking about immunization coverage. And we take that not only at the national level, but also state by state. The quarterly performance dialogue allows us to say which states are doing, what improvement are we saying? Where are we not improving? Because certainly there are areas that we may not improve. There may be things that are beyond our control. And so alongside that, we also put up the incentive mechanism, because to change a complex system like this, you also have to have the incentive for actors to behave in a certain way. So we raised resources, not only public resources, government, but also like International Development Association, the program HOPE, hundreds of millions of dollars, the multi-donor trust fund that rewards states for improving immunization rate, antenatal care attendance, skilled-birth attendance, access to contraceptives for women, those kinds of things, so that we're rewarding performance and outcomes, not rewarding inputs. Because if we only rewarded how many workshops have you had, how many meetings have you held, how many people have you talked to, that's input. But we're saying let's reward performance on the outcomes that matter to our citizens based on our discussion, understanding of their interests. So there is also incentive that is linked to indicators that are verified before federal government and states get those funds released to them.
When you say incentives for actors, I'm wondering, are you adding the medical personnel in this actors list? Because, I mean, all of the structure will not work without, the medical personnel, doing what they should do at the right time.
So, you see, there are certain things at the policy level, which is where we started this conversation. There's some that are at the system level, how it functions, and then at the care level, at the front end, where the patient interacts with the provider. So there are policy and political incentives, which the president has said this should be done, so everybody follows along. At the system level, the institutions have to be rewarded to function on what is right. And so states, local governments have to release the funds. Even if you, how do you get the frontline health worker to be enabled if the budget provided by the state is not released? So there are incentives that have been put for states, for instance, to recruit more health workers. Through HopeGov, they get rewarded if they recruit frontline health workers. And if you can provide all the resources to the health workers in the front end. If those are not the right kinds of health workers, and yet immunization coverage is going down, what do you get from it? What's the point? But by rewarding immunization, when immunization goes up, they have resources. Then you can recruit additional health workers to lower the work burden. They can provide supplemental allowances. Broadly, at the policy level, I think there are ongoing conversations with the health workforce, for instance, through the collective bargaining agreement to look at their allowances. And of course, there are things that are service-wide. Let's say it's not just one sector, but there are also unique aspects. That collective bargaining agreement mechanism is underway already, activated by the Secretary to the Government of the Federation. So we look at that. So the issue of health workers in Nigeria, certainly they are very much appreciated. And we know that many of them are driven intrinsically to serve. And that it's not just about pecuniary naira and kobo that makes them do the work. You can't pay a nurse who is in a remote area that is delivering babies. How many billions of naira do you have to reward her if you are to quantify the effort that she's doing? She's saving life. How much is a life worth, for instance, that you reward someone for it? So there's some intrinsic motivation. But having said that, government also has to do its own part. And we're advocating and working through the collective bargaining agreement to have some of those reviewed and through the salaries, income, and wages to see that, in fact, additional relief is provided. So there are many ways to deal with this issue. So the incentivization is a holistic perspective that we have of incentivization. And we've raised resources, at least at the organizational level first, through this program HOPE, to provide incentive for states. Let me also say that without incentivizing states, how can the federal government has no mandate to flog the states to do more for health. There's no way. The president can't direct just governors and say, okay, even if you don't want it, you have to do A, B, C. But by providing this pool of resources tied to certain improvements, and those improvements are channeled, are translated into actually resources for the states for achieving them. That means the states will improve the inputs, including the conditions of the health workers. So it's a different way of thinking than had been the case. You can spend a lot of effort on inputs and not achieve the results. As Tayo Oedole yesterday said, you can reward effort, you can reward results. You can reward a lot of effort, but is that really the right thing if there are no results to show for it? But you can reward results so that the effort, so this paradigm is shifting, and that's the sector-wide approach that we're putting, and we've got the support, I think, from multiple sources to continue in that. It's not perfect yet. I don't want to leave you with the impression that, oh, it's all solved. We're still struggling through many challenges and rallying. It's a complex issue, but at least we've started and we're committed to ensuring that we walk through the challenges naturally. So it's still imperfect, I have to admit.
All right, thank you very much, Honorable Minister. Let's take some messages that we have coming in. I'll begin with Architect McCoy from Lagos, who says, well spoken, Prof. How do we as a nation make progress in sectors you mentioned when we face low health insurance coverage, inadequate funding, inequitable resources distribution? And then how do we as a nation reach the sustainable mandate, which requires multifaceted approach as regards financing? All right, from Akim from Lagos, he talked about equity and access, private sector and partnerships, and he's wondering if health insurance coverage in Nigeria is still less than 10% of the population, with most people paying out of pocket. He's also talking about the private sector providing a significant share of healthcare services in Nigeria so far. And from Bolanle in Lagos, I congratulate the Honorable Minister on expanding the basic healthcare provision fund allocation. He said a welcome development for universal health coverage. However, I would like to highlight a pressing concern, the healthcare sector's brain drain, particularly in rural areas due to poor remuneration and inadequate staffing. All right, finally from Nwefuru Hyacinth. Good morning, Health Minister. Increasing the health budget can be of benefit to Nigerians only if it is matched with strict monitoring of its spending. How, for instance, if patients on admission can be made to pay a certain amount daily for changing and washing of their bedspreads, and yet they have to do the washing themselves, one may ask, does the hospital authority not make provision for that, among other things he raised?
And just to add to that, I'm sure you remembered some weeks ago when we had the Honorable Minister of State here, we're talking about the subsidy as regards dialysis, where, one of the comments we got was a particular center that has been licensed to give that subsidy wasn't. Anyways, I'm sure you respond to some of these issues. I have some questions here. This one says, good morning. The financing of the health sector by premium to health sector to guarantee perfect health is not new, but expanded with inclusion of private sector, which is a right step in the right direction. One, the major challenges are the registration of some insurance agents with poor data and reactions to the request of the beneficiaries. Registration of hospitals with poor infrastructure are major challenges of the use of the insurance paid for by citizens. Exclusion of some health challenges by some care providers. Let this be corrected in the expanded version. That's coming from Arabi Kende Paul from Life Camp Abuja. Another one says, good morning, esteemed panel. As a kidney disease patient residing in Ibadan, I appreciate the efforts to improve healthcare services. However, I've encountered some challenges with the subsidy program at University College Hospital, where it has been suggested that the subsidy is being used to settle outstanding debts rather than directly benefiting patients.
We got the same comment last time out.
I didn't even know the message was here. I just remembered. I'm currently receiving dialysis at a private hospital. I would like to share my experiences and concerns regarding the implementation of the subsidy program. All right, so another one says, what are the potential benefits and challenges of implementing the capitation payment model in Nigeria's healthcare system? And how can healthcare organizations and policymakers mitigate the risk while maximizing the benefits? What strategies can be implemented to prevent underutilization and ensure that patients receive necessary care under a capitation payment model? McCoy from Lagos sends that. I'll take one more message and then we'll go for a break. This one says, I'm Ambassador Nicholas Daniel. My opinion, government should set up teams called community health care in each state all over Nigeria. They should focus on low task force, 1,000 naira every month to build a community health care for free and set up health finance in Nigeria, and private sectors can only donate funds to assist government. Thank you. God bless Nigeria. All right, many thanks, Dr. Nicholas Daniel. We'll take a break now. When we come back, of course, we'll get responses to these questions that have come in. Stay with us. All right, many thanks for remaining with us. It's still Good Morning Nigeria live on the network service of the NTA, and our guests are still very much with us. We're talking about health financing in Nigeria. Before the break, we took some questions from our viewers, and we'd like, our guests to respond to them. I'd like to begin with Professor Ataguba. Some of the questions that we've got, what is the way? Solutions?
I think these questions are good in terms of people engaging with the Nigerian health system. One of the things I would like to see happen more often is whether you call it patient or service user complaint system, where there is a portal or an avenue where patients and service users can complain. That's one of the ways you can increase accountability and also transparency. And not just for them to complain, but such complaints must be dealt with and fed back to society so that people know and are aware that when they complain, and their complaints are legitimate and they can be met. Rather than wait and wail and complain and believe and have some kind of wishful thinking that things are going to change. Things don't change unless you deliberately want them to change. And one of the ways is to have patients or service users complain. I think you could see from people who are very keen to see the Nigerian health system improve. And for me, it's a very genuine thing to do, to want your country to move beyond where it is or where you thought it used to be. So I think that's what I really want to add, and I'm happy some of these complaints are coming through. Thanks.
All right, thank you very much, Professor Taguba. Dr. Laude, I had hinted earlier that I needed you to be able to tell us why it seems that schemes, initiatives that work elsewhere come here and then they don't seem to make the grade. Why do you think that happens, and is this different? And I think that some of the questions that came also border on inclusivity. You may want to speak about that too.
Okay, thank you very much. I'll use a particular example to illustrate our understanding of why policies are difficult to implement at times. I'll use the National Health Act, which was the National Assembly for almost 10 good years before it was passed. And when it was passed, the basic care provision component of it took another 3, 4, or 5 years before there was an allocation for it. So some of us actually look at, okay, let's examine what are the issues. Why is it that it's difficult to even design policy, implement it, and get it to work? And we discover a number of things. One is that when we design policy and people that need to be on the table to be part of that discussion, if one way or the other, some of them are not part of it, of course, it makes it difficult to implement. Number two, even if they are on the table and we don't have common understanding of what is this policy supposed to achieve, how is it going to be implemented and everything, I think that's a problem as well. Then number three is that what is the institutional capacity of those saddled with the responsibility of implementing it to do it. Then number four is that the populace, the citizen out there, that's supposed to be the end beneficiary of those policy, how engaged, how involved, and what is their level of understanding. There's a common example that people give where bed net is distributed and people actually use it for fishing instead of using it for malaria. And when people analyze it critically, they now discover that those people that are using bed net for fishing, they did not understand that it's mosquito bites that actually cause malaria. So engaging people effectively is very important. But let me now say that the way we look at policy at times, probably we have to look at it differently. We look at policy as it's designed, it should be implemented, and should be getting the result. It's an iterative process. So when we, like the Honorable Minister said, when we design policy, we use it to test the waters, what have we learned and what we could do differently. And progressively we continue to alter, like Mr. was talking about basic care provision from 2.0. It was from the understanding of the first initial implementation of basic care provision fund. What are those challenges that we've identified? What do we need to do differently? And again, another part is the accountability. People continue to ask questions. But let me quickly add to what Prof has said in terms of the questions we have received so far. So Prof was talking about getting regular feedback. I think there are some systems in Nigeria that actually do that. Some state health insurance, they have what they call grievance redress mechanism, GRM, a digitized system where in some states, if you're on health insurance, if you have any issue, we are not satisfied with anything, there's a code, you send some messages and everything, and somebody is tracking that this complaint has been lodged, who has attended to it and all those stuff. I think we can scale that to all these tertiary institutions and everything. But of course, we have local examples of where some of these things are working.
All right, many thanks.
Inclusivity?
Yes.
Inclusivity?
Absolutely.
All right, many thanks, Dr. Olawode. Let's get to Abayomi now, who is in Lagos. As we begin to round up this conversation, speak to us about what innovative solutions, or if you like, technology, that you think the private sector can bring into the health sector so that we can improve delivery and outcomes.
Thank you very much. The first one, which I alluded to earlier, will be putting in place data scoreboards, really. Scoreboards that track progress by local government, by disease, and by groups of interventions that have been put in place. So the private sector can help to implement scoreboards or progress monitoring mechanisms that show that for every naira or for every million naira spent in a particular area, these were the kind of outcomes that were received in that area. For every naira spent in training healthcare workers by local government, this can be tied back to improvement of healthcare either for children or for the elderly or for the vulnerable, like the Honorable Minister has said, or for the general populace in that locality. So scorecards will be one of them. Another would be, we've heard about drones and other technology being used to provide remote assistance to those who are far away from care. So the private sector can improve that. Telemedicine, for instance, in a more affordable, in a way that is easier for the average man on the street to use, to know that, oh, you have a problem. This is not a primary healthcare issue. To be able to reach someone virtually who can do a first level diagnosis and know if you need to be referred to for specialist care. So putting in place that would also be another. Or, linking to experts all over the world, in any part of the country, in any part of the world, to consult when faced with certain types of disease conditions. So I would say that would be another way. And the third way is just putting in place state-of-the-art healthcare infrastructure, equipment.
Abayomi, for those comments, it means that there are actually ways that the private sector can key in the health sector. But so far, we've seen that PPPs have been not too many as far as the health sector is concerned. Could you speak to us about what the challenges are really in investing in the health sector? I mean, not those who invest for, like Victor tried to say, making health a luxury, just so that it is affordable and accessible to every Nigerian. What really are the challenges for the private sector?
Well, the private sector may not know the best avenues to spend the money if they do not engage with the public sector. So if a block of private sector organizations decide to invest in healthcare, it will be good for them to consult, it will be good for them to partner with government so that they direct their spending to the places where it would have the most impact. It's not enough for companies to say, oh, we want to provide healthcare in so and so village in any part of the country. Check that is what is really needed in that area. Like has been said, there's no point going to build a very nice healthcare center if you don't have trained healthcare workers, if you don't have means of making sure they are regularly stocked with the right or correct drugs. So partner, there's already a master plan on health. There's something that says this is what is required in each area. This is what is required at each level of healthcare. The more we partner, private sector partners with government, the more we'll direct our investment to where it would be needed most.
Thank you very much, Abayomi. Let me get back here in the studio with Professor Tagba. And I'm wondering, what global models, for instance, could we learn from to improve, our own healthcare system here? Is it Ghana? Let's even go local, Africa. Is it Ghana? Is it Rwanda? Is it South Africa?
Very good question. I usually say you don't move something from A and bring it to B and expect that the conditions are the same. Many countries face that, and then you figure out this is what's happening in country A. If we bring it to country B, it's going to work. Take a quick look, even within the country. You cannot transport something or even translocate or whatever you call it from one state to the other and expect that the conditions are the same. What I would advise is something that is locally contextualized, keeping in mind the culture, the values, system of different countries, as well as leadership style. Of course, there are success stories around the world, even in Africa. You mentioned the case of Rwanda, a country that I work in significantly. I've advised Rwanda's health financing system severally. And one of the things that I think Rwanda was able to do is to find some new ways of financing health services, whether you call it innovative ways of financing health services or whatever. They generated new sources of funds to finance the health services, their health services, and they were able to go largely the non-contributory scheme route. That allows you to cover the large informal sector. If you go down to Ghana, Ghana did something very similar. They finance health services, again, largely through a non-contributory system. They devote about 2.5% of their VAT contributions to financing health. The same proportion also goes to education. So these are, in Ghana, I think that's the largest component of their health financing system that goes into the NHI for Ghana. So I would say, in summary, make it locally relevant, but it's good to learn. But when you bring it into your context, adapt it. Make sure it fits your local context.
All right, local content. Many thanks for your response. So we'll get to Professor Patti now as we round up the conversation, of course. What should Nigerians expect in should I say 2 years or should I say 5 years? When are we going to begin to see results of all these policies and programs by your ministry?
So before I respond to that, let me just add to the Ghana-Rwanda example. I think there's an important context that is often missed. Both Ghana and Rwanda are unitary states, unitary systems. We are a federal system, a different governance system that we function, and how that system is oriented, how it's run, is very different from how, let's say, Nigeria runs. If you dictate at the top, central government, it goes down to the districts. But in Nigeria, it's not the same. That's an important nuance. So when we adapt solutions from elsewhere, we have to look at the context as to localize it. Yeah. And in the context of Nigeria, the sector-wide approach that we're implementing in this administration, it has no mirror elsewhere. Is domesticated in the context of Nigeria's politics, fiscal federalism, our own culture, our own needs, and our own capabilities. And that's why we have to iterate over time to course correct, to have data, and to admit and to have the humility to know that we don't have all the answers. Sometimes we'll get it right. Sometimes we may not get it right, but at least we have the willingness to adjust if we find that what we are doing is not right. So it's not sort of absolute, and that's sort of important. The second point I would like to say is that the dimension of trust is oftentimes not appreciated, but it's so important. Generally, we're a very low trust environment. Not only in the health sector, but broadly in the context of our country, given the nature of our history and all of that, and our politics. People have had many promises made but not fulfilled. So when you come in with something new, naturally we trust that. And trust is something that is not just granted like that. You have to be also trustworthy. So I have to say that we all have to work towards earning trust of each other, and giving some latitude and taking some risks to say, well, look, if we want to move forward, then to some extent there is a certain level of, okay, let's give this a chance. Let's see it through, put some mechanisms to verify, but at least to work on that dimension as well within the context of health system. The trust environment is when you say go and collect something, or when we're, let's say, doing recruitments, people are inherently skeptical. So Nigerians themselves don't want to believe that Nigeria can be better. Whatever it is that is happening, they are looking for actually the bit to prove that it's not getting better, because they don't trust the system, they don't trust themselves. But that is something that is much deeper. It's not technical. It's really a function of a lot of experiences that people have had, and it will take time for that to evolve. It's just 2 years this administration has done remarkable things, but people find it very difficult to accept that it's true, and that in fact this is the path to go ahead, because in the past they have been disappointed multiple times. Finally, what should Nigerians expect? I think we should expect to have the system that we collectively desire to have and work towards. That common vision that we want a healthier country, an inclusive country, and a healthcare system that delivers quality and is affordable to our population, that produces health for everyone, is something that I think we have to accept, that we have to create it. The president, his ministers, the state governors, the civil society, local government, the private sector, innovators, young people, old people, have to do their own part. And to be healthy, there are also things that even households should do on their own part. Behaviors that we need to consider. We talk about smoking, exercise, what we eat, those kinds of things. It's not government that does that. Environmental sanitation, living in a clean environment, hand washing. That's not the role of government, but it has an important role. We provide maternal and child health services, but people have to go to the antenatal care. Immunization. People have to take their children to be immunized. There are children that are not immunized because their parents, even though the vaccines are there, but they don't want them to be immunized, and then they fall sick. And then we say, oh, there's high child mortality. So there are things that individuals and households and communities also can do. Our religious institutions, traditional institutions. So it's a whole of society, whole of government approach that is needed to improve the health of a population, not the health of an individual.
Very well. Many thanks, Coordinating Minister of Health and Social Welfare. Thank you so much for all that you do. We see it, and we hope that, like you have said, it would get better for us. Professor Mohammed Ali Pate, Coordinating Minister of Health and Social Welfare, it was indeed a pleasure to have you on Good Morning Nigeria.
Thank you.
I would also like to appreciate Professor John Eleojo Atagoba, Canada Research Chair in Health Economics, University of Manitoba, Canada, and Executive Director, African Health Economics and Policy Association, Accra. Thank you so much. And we hope that you remain with us. You're not going back, right? Dr. Gafar Alawade, expert in health financing. Many thanks once again for being our guest.
Thank
And yes, we appreciate senior partner at Key Business Solutions for Africa, Abayomi Olari Moye, who joined us from Lagos. So we appreciate your insights, ma'am, and we look forward to having you some other time. All right, so that's our package on Good Morning Nigeria this Friday. Beautiful public holiday. Enjoy your weekend. I'm Ian Ray John.
And I'm Victor Azu. We'll see you again on Monday.